All right, all right. Welcome everyone to our session today on measuring and responding to safety culture data. It is fine to view this session as a standalone session, but it is also the third in a series of 3 sessions from the National Action Alliance. Next slide. This webinar is going to be recorded and available on the National Action Alliance website. Please use the chat function throughout the session and ask questions at the end. And also, please know that closed captioning is available. Next slide. We want to thank you for your commitment to the Alliance and encourage all interested healthcare systems to visit the National Action Alliance website to understand the commitment process, which involves having an executive leader in safety pledge on behalf of the organization. Organizations may formalize their commitments by submitting it via email to nationalactionalliance@hhs.gov. For convenience, that email was also dropped into the chat. Next slide. Today's session is on measuring and responding to safety culture. Last month was a great session on safety culture interventions like CUSP and team steps. And before that, we learned about psychological safety. You can get those recordings and more on the National Action Alliance website. Now, culture is local. Your work setting culture impacts your behavior, and your behavior impacts the local culture. It is known as the way we do things around here. And regardless of your strategy or your intentions in any given work setting, your culture eats strategy for lunch. Next slide. Now, unlike employee engagement surveys or physician well-being surveys, the core of safety culture is in this work setting. How do we interact with each other? And in this work setting, what are the patient safety norms that drive behaviors? We assess safety culture at the work setting level. Fun fact, there's 5 times more variability between work settings in the average US hospital than there's between hospitals on average. So culture is local and change is local. That's where you assess, that's where you debrief, and that's where you do your action planning. Next slide. So the questions to run on today are: how can organizations measure safety culture and what are the benefits of doing so? But also, what specific measurement tools can healthcare leaders use to measure and ultimately improve their safety culture? So next, I want to introduce our first speaker today, who happens to be me. I'm a psychometrician and a psychologist by training. I'm a member of the Department of Psychiatry at Duke University, where I direct the Duke Center for the Advancement of Wellbeing Science. My dissertation, when I was in my training, covered the development of a widely used survey to assess safety culture and workforce stressors, and I have been doing this work now for over 30 years. Next slide. To give you a primer on what we're talking about and how this works, some general rules for safety culture assessment are: you use a psychometrically valid survey. That means it measures clinically and operationally outcomes. It measures what you think it measures. It's not just a bunch of items, but it's items that are carefully designed to measure a certain domain. And this is also predictive of clinical outcomes and operational outcomes. Those are ways of measuring survey validity. Now, we use survey results at the work setting level, and it's where we diagnose and treat at that work setting level. We get a representative response rate of 60% or more, which adequately reflects the norms and the realities of a given work setting. Good medical journals don't even accept safety culture survey manuscripts that have a response rate of less than 60%. So in order for it to be considered, real results, like actionable results, you want 60% or higher. Below 60%, that's kind of considered infotainment. We can talk about it, but we're not really sure necessarily what it means. Most surveys get between 30 and 40% response rates in healthcare, because it's just hard to do surveys in healthcare. So getting a 60% response rate is important because the first 30% of people to turn in surveys, just like the first 30% of people to do anything, they're kind of a weird and wacky bunch. So they may say, disagree, I hate my job, I hate my role, I don't have what I need, disagree. Or they may say, agree, I love my boss, and I love chicken, and I love the nurses here, and I love, agree. And to dilute basically those first kind of extreme examples, the first 30% of people who turn in surveys, you need to kind of get up to 60% to do that. That's why the 60% threshold is so important. But it's not just 60% for response rate, it's also 60% of the people reporting positive results. So let me give you an example, if I can. You can go to the next slide. Here are 60 hospitals worth of safety climate data, patient safety climate data. And it's an 80% response rate, almost 30,000 respondents. So it's a good response rate. And it ranges from about 40% reporting good safety climate norms to about 80% reporting good patient safety climate norms. But here's the same 30,000 people. And instead of looking at it by hospital, let's look at it by work setting. You go to the next slide. And here you see it ranges from literally 0% reporting good safety climate to 100% reporting good safety climate. And that's much more variation at the work setting level. How much more? Well, quite a bit more. Note that the work settings that have a safety climate score of 60% or higher, those are in the goal zone. That's a little bit more than half of that distribution is at that 60% mark or higher. That's the goal, because scores that are less than 60% are not a consensus view in ways that help drive behaviors in the right direction. So basically, if you have 50% reporting good teamwork norms, you can get away with being a jerk half the time in a work setting where only 50% report good teamwork norms. But something interesting happens at 60%. Once you get to 60%, others will push back on you. Hey, I know you're new here, but you can't talk to the nurses that way. That happens at 60% reporting good norms, but not at 50%. That's another reason that the 60% number kind of comes up. But let's go to the next slide and just say, basically, there are 5 times more variability in the average U.S. hospital between work settings than there are between hospitals on average. So it really is the work setting level that we're focused on. And let's do a deeper dive into safety climate. If we can go to the next slide, here are some example safety climate items. They include things like, I would feel safe being treated here as a patient, and medical errors are handled appropriately in this work setting. Now, you pull these items together to create a safety climate domain, a metric, a scale, which is psychometrically reliable. That means it actually measures what you think it measures, and it's predictive of outcomes like, next slide, hand hygiene. So in those work settings where healthcare workers say, I would feel safe being treated here as a patient, there are better hand washing behaviors in those work settings. It sounds simple, but there's a science to designing items that can actually do this. And surprisingly few safety culture scales have gone through this kind of validation. But it isn't just hand washing, it's also, next slide, length of stay. In this example, it was a study looking at length of stay for neonates in neonatal ICUs, and safety climate predicted length of stay of these tiny babies. But it isn't just safety climate. There are other domains to consider, like teamwork norms. We can go to the next slide. In this study of over 50,000 healthcare workers, we showed that during the global health crisis, in those work settings where they improved their teamwork norms, like speaking up and conflict resolution and asking questions to clarify ambiguities, that not only prevented problems with burnout, but it also improved patient safety climate and their capacity to even do quality improvement. But teamwork climate isn't only for workplace norms and healthcare worker well-being, it also predicts infections. Next slide. Here we showed that teamwork norms, teamwork climate predict hospital-acquired infections in neonates, but it isn't limited to babies. If we can go to the next slide, Dan Hudson showed that in adult ICUs, teamwork climate predicts the ability of ICUs to complete 5 consecutive months without eclampsia, central line-associated bloodstream infection, which at the time in 2008, 2009, that was still quite a feat. And the item that predicted eclampsias the most was, I can speak up if I perceive a problem with patient care. So in addition to teamwork climate, other important safety culture domains are things like quality improvement readiness. If we can go to the next slide, you can see these are quality improvement readiness items. The learning environment in this work setting utilizes suggestions from people who work here. The learning environment effectively fixes defects to improve quality. The learning environment allows us to gain important insights into what we do well. That's an example of capacity to do quality improvement. You measure that improvement readiness, and it gives you a sense of the pace and intensity that you can move to do quality improvement in that work setting. And as you can imagine, improvement readiness overlaps with the concept of psychological safety, feeling like you can contribute, like you can use your voice. You can go to the next slide. Psychological safety items items reflect things like speaking up and discussing errors and learning from the errors of others. And in a post-pandemic world, this domain has risen in importance as the healthcare industry has been more vulnerable in general. It's been more difficult to do standard things well in a post-pandemic world. And you can see how psychological safety is related to other domains like safety climate and even things like work-life balance. If you can go to the next slide. Here we showed a nice linear relationship between safety climate or safety culture, rather, domains, and better healthcare worker work-life balance behaviors. So when there's better teamwork climate and there's better safety climate, this means that healthcare workers are much more likely to take breaks and eat meals at mealtime and leave work on time at the end of the day. And speaking of well-being, we can go to the next slide. What if I were to tell you there was one metric, one domain that you can measure in safety culture that is so potent that it predicted clinical outcomes and operational outcomes and safety culture and well-being, and it's like the one ring to rule them all? That domain would be emotional exhaustion. Healthcare worker emotional exhaustion is a very powerful predictor of clinical outcomes, operational outcomes, everything from infections to mortality to disruptive behavior rates to communication breakdowns to turnover, you name it. Emotional exhaustion of the healthcare worker measures all of that and more. And if we can go to the next slide, it is because emotional exhaustion is the best shorthand we have right now for healthcare worker well-being. It's associated with all those outcomes, and it really just represents your ability to do stuff. So as your well-being is compromised, your ability to do stuff is compromised. No wonder healthcare worker emotional exhaustion rates do such a great job of predicting outcomes. And lest that be kind of intimidating to you, we can go to the next slide. Emotional exhaustion can be measured for free using psychometrically valid scales like this 5-item derivative of the original 9-item emotional exhaustion scale. And that the shorter scale means less burden on healthcare workers, but it's still valid. And healthcare worker emotional exhaustion is an interesting area of research for healthcare workers right now. We can go to the next slide. There is a language pattern used by healthcare workers that predicts their future emotional exhaustion state. You can use linguistic predictors of their future well-being. If you go to the next slide, this was an interesting study that used comments, just the comments, the open-ended comments from safety culture surveys in year 1 to predict the emotional exhaustion scores of those same survey respondents in year 2. So we use all the data from these surveys, and there's a language of emotional exhaustion. Interestingly, there were 5 linguistic categories that predicted your current and your future kind of burnout state, your emotional exhaustion state, but your current emotional exhaustion state did not predict future language use. So language really is a predictor of exhaustion, but it doesn't go in the reverse. So let's move on to how we can change safety culture, and I really want to get into the power of leader rounding. It's such an important topic for moving safety culture. If we can go to the next slide. Back in 2012, we started collecting data using different safety culture surveys like the Safety Attitudes Questionnaire and the AHRQ SOPS survey. Instruments, and we looked at the extent to which healthcare workers, everyone filling out the survey, not just individuals, but everyone who filled out the surveys, to what extent did they report getting feedback about actions taken as a result of walk rounds? So did you receive feedback about actions taken as a result of leader rounding in your work setting? Yes, no, not sure. And if you just look at the ones that say, yes, I received feedback, that suggests that not only is rounding happening, but it's happening repeatedly in your work setting, and the people who are doing the rounding are coming back to report on the results of the actions taken. So that really kind of it suggests a more robust rounding program when you ask the question that way. And what we found was interesting. If you look in this figure here, the SAQ, the Safety Attitudes Questionnaire domains of safety climate and teamwork climate, which we've already talked about, were very responsive to leader rounding. So were some of the AHRQ domains like overall perceptions of safety score and your error and feedback about communication scores. Those were also responsive to leader rounding. But interestingly, the burnout of these healthcare workers was also trending in the right direction. So more rounding, less burnout, which was interesting. And it got us wondering, I wonder if we could do something to tweak the way we're doing rounding that would be a different kind of rounding, but actually target the well-being of the workforce more directly. And here you can go to the next slide. So the first thing we did was we get a large sample. In this case, it was 121,000 healthcare workers to see if we could replicate this walk rounds and feedback about walk rounds and the impact it had on burnout. And yes, it did. Not only did we see really clear results for burnout, but more rounding was better culture, whether you're talking about improvement readiness, your leadership, your teamwork climate, your safety climate, you name it. So this next thing that we did, if we go to the next slide, is we looked at positive rounding. So instead of saying to folks, how are we going to harm the next patient around here and what can we do to prevent that, we would say, tell me 3 things that are going well around here. What are you looking forward to? Who do you want to give a shout out to? And what's something that gives you meaning at work? Oh, and what's one thing, if we could fix one thing and make that better for you, what would that be? So we were asking good in addition to the deficits, and it worked well. It worked quite well. It worked exceedingly well when we did it as a positive rounding, which led us to our next study. And in this study right here, we compared traditional safety rounding, that's the panel on the left, to positive rounding, where we ask about what's going well. That's the panel on the right. You put them into a horse race, and what's interesting, you'll find that both safety rounding and positive rounding work on your culture, but positive rounding works better. It's not just rounding, though. There are other programs like peer support that can make a big difference on your safety culture scores. You can go to the next slide. And here we looked at people's perception, healthcare worker perceptions of their peer support program. And if you're a healthcare worker and you assess that your mothership, your institution has your back on your worst day at work ever, when you're involved in some harm to a patient, if you feel like your mothership has your back, you fundamentally view more positively quality improvement, leadership, teamwork norms, patient safety norms, and the well-being. And that's important because burnout is on the rise. If we can go to the next slide, we've tracked the same 30,000 healthcare workers completing safety culture surveys over 3 years. This is before to after the pandemic. And we showed that for every healthcare worker role, every single role, clinical and non-clinical in healthcare, emotional exhaustion got significantly worse over the 3 years of the pandemic. Nobody escaped unscathed. But there's some good news here that we can actually measure healthcare worker well-being on these safety culture surveys. If you go to the next slide, we've done randomized controlled trials, multiple randomized controlled trials using these well-being domains of things like emotional exhaustion and work-life integration, and to what extent are you thriving, and to what extent are you able to bounce back after upheavals. That's exhaustion, work-life climate, thriving, and recovery. And yes, all of those are movable with bite-sized interventions, simple interventions to help people with their well-being. But also, those same domains are easy to include in safety culture. So you have a safety culture and workforce well-being assessment. And that means one survey that serves the HR needs, the patient safety needs, and the chief wellness officer needs all at the same time. We can go to the next slide. I want to kind of wrap this up, if we can, and just say we also have published how to debrief safety culture results. You do this by focusing on both your local strengths in this work setting, as well as some opportunities for things to get better in this work setting. And these debriefing practices have been linked to better clinical outcomes, as we did in this study, which is using ICUs and bloodstream infections and PEDVT rates, bloodstream infections and CAUTI rates. So if we can go to the next slide, I just want to reflect and review. We've covered a lot of information here in a short time, but just to remind you, we're looking for a psychometrically valid survey at the work setting level with a good response rate. And if safety culture domain scores are less than 60%, if you have fewer than 3 out of 5 people saying, yeah, it's going great around here, if you have a less than that consensus, we know that that's a target area. So let's make sure that we can apply what we've learned today in this very rapid fire safety culture masterclass, if you will. So if we go to the next slide, here is actually a set of safety culture results. These are real results from Duke University Health System. These are all work settings within Duke University Health System. And one particular work setting, which you can see up there, work setting C, you can see their teamwork score, and you can see their local leadership score. How do they view their leader? You can view their safety climate score, as well as their quality improvement readiness score. And you can see that all 4 of those scores are less than 60%. But this is a trick question. I'm going to give you the answer just so you can have it. The real question, if you go to the next slide, is What was their emotional exhaustion score? And what you can see, this same work setting, which is struggling with teamwork and safety and leadership and doing quality improvement projects, it looks like it's really struggling with well-being. They have not got the gas in the tank that they need to do teamwork correctly and to do patient safety norms and behaviors correctly. And so if we understand the kind of Maslow's hierarchy of needs, what we're seeing here is people don't have the well-being gas in their tank to do the quality improvement, to do the communication, practices, the briefing and the debriefing and the daily goals and things like that. The reason that they're not doing it isn't because they don't know how, it's because their battery is low. And so if I can leave you with one nugget for today, it'd be this. If you go to the next slide, it's that culture eats strategy for lunch. It's a huge predictor of everything important to us in healthcare, but burnout eats culture for breakfast. We have to make sure that we're paying attention to both the patient safety norms as well as just the well-being of the workforce. They're both just so very important. That Venn diagram is so overlapping and important for us to really give some TLC to. So with that in mind, let's go on to our next slide. I want to introduce our next two speakers. Jonathan Bakdash is a social science analyst at the Agency for Healthcare Research and Quality. He is the lead for the surveys on patient safety culture, which we've been talking about, and has more than 20 years of experience conducting research in healthcare quality, decision-making, and culture. He has a doctorate in cognitive psychology from the University of Virginia. And the next speaker is Joanne Sora, PhD. She's an industrial organizational psychologist at Westat, a vice president with more than 25 years of experience conducting organizational and health services research. She directs a contract that supports AHRQ's consumer assessment of healthcare providers and systems, and the surveys on patient safety culture. So she has expertise in organizational culture, patient safety, patient and caregiver experience with healthcare, implementation science, program evaluation, and survey methodology. We have some similar background. That's why I get excited to introduce Dr. Sora. But with that, let me hand it over to the two of you for our next session. Thank you all. Thank you all very much.
Thank you so much, Brian. Today, Joanne and I are going to give an overview on AHRQ's Surveys on Patient Safety Culture SOPS program. And Joanne, in particular, is going to focus on user improvement stories using the SOPS instrument. Next slide, please. AHRQ's SOPS program has been around since 2001, and it aims to advance understanding of patient safety culture within healthcare environments. The SOPS program has developed reliable and validated surveys for measuring patient safety culture and trying to use these best available methods for development and testing of the instruments. And there are also tools for trying to improve patient safety culture, because it's not enough just to measure it, as you're seeing. You also need to take some actions to improve it. Next slide, please. To give you an idea of some of the areas of patient safety culture that SOPS surveys assess, it includes things like communication openness, response to error, staffing and workplace, work pace, teamwork, and we also have supplemental items that measure things like workplace safety, diagnostic safety that go with some of the instruments too. Next slide, please. There are various care settings for SOPS surveys. So the SOPS surveys are specific to particular environments. And this includes hospitals, medical offices, ASCs, ambulatory surgery centers, and nursing homes. We also have a community pharmacy survey. And these surveys are intended not just for healthcare providers, but also for staff, and it's to measure perceptions of patient safety culture. All of these are voluntary databases. Next slide, please. So why do you want to use an AHRQ SOPS survey? So I want to focus on the third point first and foremost, and that is the most important one, is the SOPS surveys, like other validated safety culture surveys, are associated with important quality and safety outcomes, as you heard described earlier. And that is kind of the biggest reason to use a SOPS instrument. Some of the additional reasons are they were developed with extensive input from experts and healthcare professionals, do comprehensive testing for reliability and validity, Because they're widely used, there are benchmarks available. If you submit your data, you get a private feedback report, so you can see your organization's strengths and weaknesses relative to other similar organizations. And also the instruments are free, and we also provide free technical assistance. Next slide, please. So in terms of some of these associations with safety culture scores for the SOPS instrument and important outcomes, we have a variety of research that has shown lower rates of surgical site infections, lower readmission rates, better financial performance, and operating margins with use of an electronic healthcare record system, lower adverse events, and also higher hospital patient experience scores. So high SOPS scores are linked to better outcomes along these variables. Now I'm going to hand it off to Joanne Sora with the stat. Next slide, please. Oh, and I did that too soon, didn't I? Sorry,
That's
Joanne.
fine.
One more slide. So in addition to this, the workplace safety scores for the SOPS, and this is a supplemental item set, are also associated with more positive patient safety culture, better job satisfaction, more likelihood to stay, and lower stress and burnout. And you saw burnout, emotional exhaustion. It was a major focus point of Brian Sexton's presentation. And now I'm actually going to hand it off to Joanne Sora. Thank you.
All right. Thanks, John. So I'm going to start with 3 success stories from hospitals that have used the AHRQ surveys and tools. And these stories are from AHRQ webcasts, and you can download the slides and watch a replay of their full presentations if you enter AHRQ webcast in your browser, and then it'll go straight to the page. So the first story I'm going to start with is from the Indiana Hospital Association that in 2023 administered the SOPS hospital survey with the workplace safety item set in 37 hospitals. And they received over 14,000 responses. And they got to that response rate by, that level of response by offering pizza parties, department awards, and then they actually gave a candy bar or free cookie to everyone who responded, and they offered a QR code so that it would make it easy for staff to complete the survey on their cell phones. They then identified from those results these areas for improvement, really focusing on workplace safety among providers and staff. So they wanted to address physical and verbal aggression from patients or visitors, verbal aggression among the providers and staff, and then work stress and burnout. And they implemented, to address these areas, they implemented a workplace safety training program called RISE, which stands for Resilience in Stressful Events. And RISE is a program developed by Johns Hopkins, and it's a training of peer support for providers and staff dealing with trauma from medical errors that they witnessed or were involved in. And it also addresses burnout and other workplace stressors. So the IHA partnered with the Maryland Patient Safety Center to deliver a 2-day live virtual training with more than 13,000 FTEs across 13 hospitals. So it was quite an investment. And what they're going to be doing is then convening these peer responders in a quarterly community of practice to share lessons learned, and then they'll implement asynchronous training in the future. And the link here at the bottom will take you to the replay of that webcast to get their slides and hear more about their story. Next slide, please. So the next success story was also a webcast focusing on Riverside Walter Reed Hospital in Virginia. And there, leadership at all levels, including system level boards, the C-suite, facility level boards, actively engaged in supporting quality and patient safety initiatives. They believed a robust safety culture is the foundation of safer care and improved patient outcomes. So they annually administer the SOPS hospital survey, and they examine trends over time. And as they administer the survey, they make sure each year to communicate any improvements or initiatives that they implemented based on the feedback from the prior year's survey, to let the staff know that they are paying attention to the information that's coming from the surveys. And then they used trendy raffle prizes to increase response rates. They provided weekly response rate updates to the departments and units to promote friendly competition, and they continually promoted the survey during data collection. They also then reviewed the results one-on-one with each department leader and then examined trends over time to track improvement. They identified handoffs and information exchange in med-surg units as an area for improvement because they had had several safety incidents. So they interviewed high-performing departments to understand the reasons for success in handoffs, and then extended those best practices to other areas and other Riverside facilities. They also used the SOPS action planning tool and developed a new tool to standardize their handoffs. The action planning tool helped them take a structured approach to identifying what to focus on, setting specific goals, and tracking their progress. And then they pilot tested this new handoff tool to standardize handoffs, integrating into their daily standard of work. And then they tracked progress, provided weekly updates, quarterly and monthly to maintain momentum. And they found that they had to rework their handoff tool, the layout of the tool, what was included in it several times to ensure that it met the needs of patients and nurses. And then when they redid their survey results in 2023, they actually showed a 30 percentage point improvement in handoffs and information exchange. Next slide. And then the final story I'm going to cover here today is from UNC Chapel Hill's surgery department, where they had 11 years of data on the SOPS hospital survey, where they were examining trends over time to get a deeper understanding of their culture. And they conducted teamwork and communication training using AHRQ's Team Steps 2.0 curriculum, but they added a really cool virtual reality simulation component to that. So basically, they showed video scenarios from different points of view, different perspectives from each of the surgical team members, showing how that team member would perceive an adverse event as it was happening. And so the video vignettes were of a patient. They were closing a patient after surgery. The patient loses a pulse and then ends up dying. And so the purpose of the virtual reality simulation was to really evoke the stress and the feelings and the emotions that staff would experience as if they were in that scenario and seeing what was really happening from each team member's perspective. And so what they did was they focused on the 4 core aspects of teamwork that are in the Team Steps curriculum, which are communication, leadership, situation monitoring, and mutual support. And they trained med students to observe actual surgeries, and then using this observational assessment tool called TENS, which is Teamwork Evaluation of Non-Technical Skills, these med students basically rated the communication and teamwork behaviors before the training and then after the training. There were 10 physicians that were trained and then 10 that were in a control group that weren't trained. And so the med students then coded their behaviors on the TENS tool, and they found that the 10 trained physicians showed improvements in 90% of their teamwork and communication behaviors compared to the 10 physicians from the control group. So I encourage you to, again, go to this webcast. You'll see a little bit of a video vignette from this virtual reality training and hear a little bit more about how they implemented this intervention. Next slide. So now I'm just going to shift a little bit and talk a little bit about some of the SOPS data and resources. So now the SOPS hospital survey results from the SOPS database are on the National Action Alliance dashboard, and it's from database years 2021, 2022, and 2024. And I'm not showing the screenshot here, but if you go, you can see in the database report as well that there was a large decline in perceptions of adequate staffing and work pace as a result of the pandemic in 2022 results. And then in 2024, we're just starting to see that bounce back, but not quite at pre-pandemic levels. And similar results you can find for management support for patient safety. So as Brian was mentioning, we're still recovering from the effects of the pandemic on the healthcare staff and on patient safety culture. Next slide. The SOPS databases are open for data submission for the Ambulatory Surgery Center survey in June and the Medical Office survey, along with the Diagnostic Safety and Value and Efficiency item sets, supplemental item sets, and that Medical Office data submission is in September. So if you're interested, you can go to this webpage, or you can contact the technical assistance line. Next slide. And so the AHRQ website is www.ahrq.gov/SOPS. And you can get the surveys, users guides, other resources, information about data submission, and the webcast replays and slides that I was referencing for those success stories. And these are the technical assistance emails for the databases, and just for general technical assistance, databases on safetyculture@westet.com. and safety culture surveys at westet.com. And then to sign up for GovDelivery email notifications, you can go to the homepage of the AHRQ website in the top right-hand corner under email updates. Next slide. So I do want to cover a little bit about the Centers for Medicare and Medicaid Services Patient Safety Structural Measure for 2025. I'm sure you all are probably aware of this, and it's an annual attestation-based measure that assesses whether hospitals have a structure and a culture that prioritizes patient safety. And it includes 5 domains, and then there are subdomains within each of these, but we're going to focus on domain 3, which is culture of safety and learning health system. Next slide. So statement A under this domain says that you have to attest that our hospital conducts a hospital-wide culture of safety survey using a validated instrument annually or every 2 years, with pulse surveys on target units during non-survey years. Results are shared with the governing board and hospital staff and used to inform unit-based interventions to reduce harm. And so some of the examples of validated instruments that are in the attestation guide include the SOPS survey and the Safety Attitudes Questionnaire, or SAQ. Next slide. So in domain 3, statement A, it talks about this pulse survey. And so a pulse survey, they're describing as a short set of questions, typically 5 to 15, administered on a more frequent basis than annually to provide continuous feedback. And then because some hospitals will administer a culture survey every other year, then the pulse survey could be administered during the non-hospital-wide survey years. And it doesn't have to be administered throughout the hospital. It can be administered on selected units or with selected staff. Next slide. And so because the SOPS hospital survey is longer than 5 to 15 items, the guidance that we're providing is that if you want to develop a shorter pulse version of the hospital survey, you would select a subset of the composite measures. And those composite measures consist of 2 or more items that are measuring the same area of patient safety culture, like teamwork or staffing. And then you'd include all the items from those composite measures. And then you can add additional single item measures or supplemental item measures. And then this preserves the ability for your hospital to compare with the hospital database and compare with other hospitals, and to compare your own results from the full survey to the shorter pulse survey. Next slide. So other tools that can be used to measure safety culture include Patient Safety Climate Healthcare Organization Survey, Safety Attitudes Questionnaire, the SCORE survey, and then of course there are proprietary instruments by survey vendors. Next slide. And these are just references. So that's the end of my presentation.
Thank you for that presentation. I know that safety culture is not the most exciting of topics to talk about, but we have somehow managed to make it different and interesting. And so thank you both for that very much. And it's now time to really open it up for questions. I ask all of our folks that are listening live to head over to the chat and feel free to ask us questions through the chat. One of them that just came through, and this is, I think, for Dr. Sora, is the CMS Domain 3 for safety culture, does that apply to outpatient clinics or only to hospitals?
Just to hospitals, and it looks like someone else responded. So thanks for that. That it's for the inpatient prospective payment program, and so it's just for hospital setting.
Excellent. Let me see here. Here's a question. Is there any concern that if you do not use the whole survey during a pulse administration, that it will change the validity and the reliability?
So there's some concern, which is why in our recommendation, we're suggesting that you select composite measures. So if a composite measure has 2 items or 3 items or 4 items, include all of those items, so that, because we've demonstrated that those items together have good reliability. You're not just selecting 1 out of 4 or something like that. So I think that's our best guidance at this point, to create a shorter version from some of these longer culture surveys. And I don't know if, Brian, you have any advice on any of the other surveys.
I think that given the exhausted state of the average healthcare worker globally, going to shorter assessments we're going to have to do that because we're just going to see lower and lower response rates. And if you put in all this effort, like we've got 45,000 people at Duke, if we put in all this effort and then we end up getting back a survey with like a 35% response rate, we just wasted the time of the people who filled out the survey, and we didn't actually get the data that we needed. So making it a shorter survey so you can up those response rates and make the data that you do get back more actionable, I think is really important. I also think that if you want to go the route of pulsing, what I think you should do is, in advance, before the pulse year, if you want to have like these 3 or 5 whatever items that you're really focusing on, name them in advance. Don't cherry pick which items happen to go up or which items happen to go down in a given year. But say in advance, like when we do our pulse, these are going to be the items that we include in the pulse, because this is why this is what the logic is behind that. That's just kind of a standard practice. But there's some more questions here I'd love to hear. And if you disagree, please feel free to push back on anything that I'm saying here, because I'd love to hear if you all have different thoughts on that as well. Okay for now?
Yes.
All right. Here's another one. This is a great question. Thank you, Kathy. Any tips on getting physicians to participate in the safety culture surveys? Do y'all want to go first?
Go ahead.
All right. I love giving people continuing education credit. I love to go to grand rounds and then encourage people as part of the grand rounds on safety culture to fill out a safety culture survey and then give an hour of CME to all the physicians that showed up for grand rounds that morning. That's a lot of work. You have to go around and do that. You can do that in pre-recorded and during credits. Also, for physicians, having a shorter survey that answers questions that are important to those physicians are really big drivers of physician response rates as far as the research that we've been doing. But I don't know if y'all wanted to add anything to that for our physician, our busy, tired, cranky physician respondents.
We haven't really seen a lot of folks offer specific guidance, so I think that's really great, Brian. And I think the one thing that we do here is to increase response across the board, these little incentives, these pizza parties for units that get response over 60, 70, whatever you want to set the bar at, 70%. And then they also will sometimes give them a certificate, to pick up that cookie or to pick up, a snack in the cafeteria. So little things like that are incentives that help drive. And then providing response rate feedback to the department managers and the heads so that they know, relative to the other departments, like, okay, our department is slacking. I need to promote this a little bit more, little friendly competition.
I'll add to that the year we had our highest ever physician response rate, we had an 88% response rate amongst our physicians, which is unheard of for culture surveys like this. And it was because we had our chief medical officer um, making a really big deal about it in all of his rounds as he went and talked in committees, and he was doing his own kind of virtual meetings with folks. He really talked it up to his physician colleagues and physician leaders and department chairs. And boy, having something driven by a physician leader really made a big difference in physician responses to the survey. So that's another thing, just to tuck it away for what it's worth. That was our kind of banner year for including physician perceptions.
Can he be hired out to other hospitals?
But we want him. We want to keep him. We want to keep him here as best we can. Here's another really interesting question that is right up y'all's alley as well, which is positive questions and negative questions. It says we've made negative questions. Is that okay to make negative questions? Like negative, I'm assuming this means negatively worded items, like it's difficult to speak up, and you can agree that it's difficult to speak up, which is bad. How do y'all feel about negatively versus positively worded questions?
Yeah, we have seen that, and certainly gotten the feedback on the SOPS surveys because they contain negatively worded items, that it's sometimes difficult for people to recognize that, and it's difficult to communicate the results because it's like the percent positive on low staffing. And so understanding that, like we've reduced the number of negatively worded items sort of moving forward. But sometimes there are certain, the reason they're in there is because there are certain concepts that are just hard to measure in a positive way. Like I feel like my mistakes are held against, people feel like their mistakes are held against them. Like, yeah, you can say that in a positive way, but it's sort of getting at something qualitatively different. And so that's why they were there. But we certainly understand the difficulty and the drawback of including those questions.
I totally agree. Having a few on there is not a horrible thing because it also makes people slow down a little bit, and they're not just like agree. Like, oh my gosh, I have to disagree with this thing. And I find that adding a couple of negatively worded items, just a couple, it improves the quality of the response on average for respondents. And so a little goes a long way, though. I totally agree for negatively worded items. Here's one. Are there areas or composites of the survey that drive culture improvement more than others? Like, does improving just culture show improvement across other domains? I don't know if you wanted to talk about that first.
You can, if you want to go first, go ahead.
Well, I gave my Lord of the Rings reference already. I think that the emotional exhaustion is the one domain to rule them all, because if you have high exhaustion, it doesn't matter if your teamwork is bad and you want to kind of give people team training. If the exhaustion is through the roof, teaching someone how to speak up isn't very helpful. It actually can be counterproductive. You can make people angry, like just make my life easier. Don't give me some new checklist to use when I pick up a phone. Kind of a reaction to things. So I think that the well-being component is a superordinate component in that sense. And beside that, I wouldn't call it just culture necessarily, because that might be trademarked by David Marks or something. But I would say it's like psychological safety. Yes, from a pure culture, like not a well-being perspective, if you don't feel comfortable speaking up, asking questions, contributing to the conversation, that is going to affect lots of different domains. That's going to affect your teamwork and your leadership assessments and your quality improvement, participation, and all these other things. So I would say kind of psych safety and emotional exhaustion they kind of punch above their weight for kind of impact.
Yeah, and I would add that on the SOPS surveys we see, and on the supplemental item sets, we see that management support for patient safety, that they provide the resources, it's a priority. That is something that drives the overall rating, and it is highly related to the other measures. And then we've also done some research that has linked workplace safety, so the safety of the providers and staff. So if they feel like they are safe, and then that is related to their perceptions of patient safety, and patient safety culture is related to patients' experiences of care on CAHPS measures in hospitals. And so all of these measures are really linked together, like inextricably. And so if you are moving the needle on your patient experience, you're probably moving the needle on safety culture and on management support, and on workplace safety, which includes work stress burnout, right? Improving that. So it's like there's a positive cycle among all of these areas of culture and patient experience.
So this is another kind of interesting one. What are your recommendations or programs to encourage a teamwork culture? That's a fun one. I've got an opinion about this too.
Okay.
Well, we saw that when we went live with Epic at Duke, we took a real hit on our teamwork scores, and we took a real hit on our well-being scores. Both of those really took a hit. And what we learned kind of the hard way was those work settings where we jumped in and worked on well-being, their teamwork went up without doing anything specifically for well-being. And those work settings that had taken a hit for teamwork and well-being, but instead we just focused on teamwork. Like, here's a new way to use, kind of daily goals. Here's a new way to coordinate care. That was met with some real pushback and hostility. And in fact, well-being continued to get worse in those work settings, and we didn't really move the needle very much on average with the team, with just teamwork for teamwork's sake. So that was another kind of example of how we learned, we need to make sure that we're paying attention to the well-being of the healthcare workers before we assume that what they need is more training in X or Y or Z, and that when we do that, when the well-being improves, their psych safety improves, their teamwork improves, their ability to use protocols correctly improves. It's kind of like an interesting driver of some of those other behaviors. So I would just say to kind of simultaneously pay attention to teamwork and well-being, and that that the Team Steps program is as good as it gets that I'm aware of right now out there as a good evidence-based, well-oiled kind of program that can be customized to kind of local needs in certain ways. But that's my kind of 2 cents on teamwork culture.
Yeah, I wouldn't add anything more to that. I think that was a great answer. Yeah.
All right, we have any recommendations on determining who or what areas to pulse?
I mean, I guess I would say, we thought about this, like, is there a standard, advice that we would provide? And I think we wouldn't. And as you advocate for, Brian, culture is local, it's at the unit level. You could ask your departments and your units to say, okay, well, what do we want to focus on? It sort of depends on how customizable you want that pulse survey, or whether you want it across the whole hospital to compare across hospitals. But really just thinking about, for that year or for that period of time where you're trying to do a pulse survey, are you doing some interventions that you really want to see the impact of, right, on this pulse survey, because you're going to be assessing more often, or in selected units. So if you've got an initiative of Teen Steps or walk rounds or puddles, maybe focus on the domains that are really sensitive to that, like speaking up and communication and teamwork. But it really kind of depends on what you all are focusing on, what's important, and what you want to see, move over time, and what you really want to focus on.
100%. I think that pulses have to be considered very carefully, because if your goal is to use a pulse in kind of like when you're not giving the full survey in that off year, if you want to use that pulse and you're not surveying everywhere, be mindful that usually leaders want to pulse those work settings that had lower scores, and lower scores are generally associated with lower response rates because there's lower engagement on average. So it's going to be harder to get a good response rate from a work setting that's been flagged as having some challenges. So just be mindful of when you pulse because of low scores. Be ready to kind of make a deliberate effort, to provide, for example, protected time, during a staff meeting to put up a QR code and complete the survey like as part of your staff meeting, so that there's like protected time allocated to do something like that for if you're really wanting to make sure that you're getting good data back. But here's an interesting kind of flip side of that. That was about short surveys. What about long surveys? This is one from Jen Murphy. Any insights on combining culture surveys with employee engagement surveys or NDNQI surveys? Yes, they'd be longer, but then one survey rather than surveying multiple times a year. Ooh. So what do y'all think about that?
We certainly see it, and I think it's fine as long as there are clear like breaks or page like announcements, titles, or whatever to say, okay, this is the engagement part. These questions are around engagement. Now we're moving to safety culture. Now we're moving to emotional exhaustion or work stress, burnout, so that people are really cued in. Okay, I'm not just still now answering about employee engagement, because sometimes the questions can be seen as sort of similar. They're focusing on communication or management support, things like that. But yeah, you have to probably see for yourself how many surveys can you put together before you're just not getting response. But yeah, there's some advantages and disadvantages, because otherwise you're going out twice a year with these different surveys too.
Yes, I have a couple more minutes. I'm going to put up a note at the end for upcoming events, just as a quick placeholder. But yes, just to piggyback on top of that, I would say like the SCORE survey it measures safety culture, workforce well-being, employee engagement, and it's Leapfrog and Magnet approved. So that is one survey that is designed to do all of those things, but it's long. And so you have to be very deliberate about when you administer that it's going to take longer to fill that, especially for nurses who have, in addition to everything else, they have to fill out the nursing magnet kind of components of it. So I think that long surveys like that, here's my advice, if somebody wants to do that, make sure you have a good relationship between your chief wellness officer, your patient safety officer, and your HR leadership. And if they work together in the sandbox very well, then they can share the results very well from that. If they are not accustomed to working together, trying to start them working together by doing a joint survey is not always a great idea, because you realize that we don't always agree about the same things that we need to be agreeing on for this to be an effective process. So it took us several years to get our well-being and risk and quality improvement folks and our HR and engagement folks kind of all aligned. It didn't happen overnight. So that would be my advice. If you're going to do a combined survey, just make sure you have alignment between those different leadership factions. It can be a beautiful thing or a nightmare, depending on how well we get along in advance. Here's a simple one, I think. Is pulsing more of a recommendation or a requirement?
I can take that one. So CMS, for the patient safety structural measure, pulse surveys are offered as an option, but they're not required. You could do a full survey, and so it is a way to measure things kind of in off years rather than doing a full survey administration. So you should view it as kind of being optional, but you may get higher response rates. You may be able to focus in other areas with a flexible pulse survey option. So it should be viewed kind of mostly as optional and kind of a faster alternative than having to do a full survey administration every year. Safety culture.
Agree. I think not enough people take advantage of pulses. There are many people that give long surveys frequently, and they could be taking advantage of the pulsing in the off year. I think that's a good recommendation. I think the jury's still out on how people kind of use or misuse or utilize, that particular recommendation. Here's a fun one. Maybe I'll try to end it on this one. Given Brian's assessment of more valuable environment or more vulnerable environments post-pandemic, what advice do you have for the near future, in addition to shorter surveys, for health organizations to most effectively and improve safety culture? I have to say, the job of being a leader in healthcare is just infinitely more complicated now than it was a year ago, and it was infinitely more complicated then than it was 5 years ago. I think you have to be very good at communicating and very good at doing simple things and talking about those simple things in simple terms. So the day of the highfalutin language used by leaders that impress with their kind of vocabulary is kind of a thing of the past, and you have to be able to speak plainly and clearly about simple things, because the attention span is at an all-time low, and the desire to move on to the next thing is at an all-time high. So being able to speak clearly and simply is really, really important for leaders right now in terms of making progress on workforce well-being and patient safety culture. And with 1 minute remaining, can we throw up the very last slide? I just wanted to say, just to give people a heads up on our upcoming National Action Alliance events. Just so that you know, coming up on May 7th is a webinar on the patient safety indicator gap analysis findings. That's May 7th from 1 to 2:30 Eastern time. And then also on the next slide, we have implementing the CMS patient safety structural measure, which you heard about today, thanks to our guest speakers, on May 13th from noon to 1 p.m. Eastern time. Please don't be a stranger. Check out the recordings of our previous sessions on the website, and a great big thanks to our guest speakers today. Thank you so much for joining us, and we hope to see you again next month.
Thank you.
Thank you.